Hello, my name is Mark Munievo. I'm the CSO of the Children's Tumor Foundation Europe, and I wanted to welcome everybody to the last masterclass of 2023, which today will be held by Sabine Koenig and Bertolt Pemp from the Medical University of Vienna, and which will be focused on purely ophthalmologic matters in both NF1 and NF2 related schwannomatosis. I need to give you a few instructions before we launch the masterclass. You will not be able to interact directly with the lecturers. I will be moderating the questions. And to that end, I need to ask you to use either the Q&A box or the chat box to ask your questions, and we will answer them after the masterclass, which is pre-recorded and which I am going to launch now. Thank you very much.
Ladies and gentlemen, dear colleagues, at first I would like to express my thanks to Mr. Nevio for the organization and invitation to this lecture. I'm very pleased to be able to give today's lesson about the topic eye examination in neurofibromatosis type 1 and neurofibromatosis type 2 related schwannomatosis. A few words about me. I'm certified orthoptist and have many years hands-on experience in NF1 and NF2 patients. Ophthalmologic and atopic signs and symptoms in NF1 and NF2 related schwannomatosis. Optic pathway gliomas and optic nerve gliomas occur in 15 to 20% of NF1 children. The tumors can be located in the anterior optic pathway, the chiasm or hypothalamus, and may lead to vision loss, visual field defect, relative afferent pupillary defect, strabismus, ptosis, and color vision disorders. Orbital, periorbital, plexiform neurofibromas occur in less than 10% of NF1 children. The leading symptomatosis is seen in nearly 100% and can be associated with orbital abnormalities and sphenoid beam dysplasia. All this can lead to vision loss, ptosis, squint, amblyopia, anisometropia, and eye motility disorders. The main symptom of NF2-related schwannomatosis are bilateral and unilateral vestibular schwannomas. It predisposes to other central and peripheral nervous system tumors, cranial nerve pulses 3, 4, 6, and 7. Juvenile cataract, retinal hematomas, and epiretinal membranes are typical ophthalmological manifestations in childhood. Optic disc gliomas and optic nerve sheath meningiomas are additional NF2-related features. So the spectrum of ophthalmologic atopic signs and symptoms ranges from vision loss, visual field defect, squint, ocular motility disorder, and paretic strabismus, eyelid abnormalities, up to nystagmus, and vestibular dysfunction. Focal points of an optic examination in NF children. In NF1, both optic pathway gliomas and orbital, periorbital, plexiform neurofibromas are mostly diagnosed in the first years of life. Attention deficit hyperactivity disorder and increased distractibility can be additional manifestations. This may be an optic challenge in young NF1 children because on one hand there are a lot of examinations to perform, and on the other hand the children often have difficulties to concentrate. In NF2, the initial manifestation differs between children and adults. Teenage and adults usually suffer from vestibular symptoms like hearing loss, gait disturbance, dizziness, and nystagmus. In infants and young children, the ocular manifestations may be the first sign that lead to the diagnosis of NF2. Two authors, Walsh 2006 and Nordiosko 2019, described in their retrospective studies visual complaints like vision loss and strabismus as initial symptoms in 39 and 41% respectively. So a regular eye examination and visual function testing are important devices. The main focus of the optic examination is on age-appropriate visual acuity testing and reflection measurement, perimetry, and optics, including the examination of eyelid abnormalities, exophthalmometry, careful examination regarding strabismus, eye motility disorders, and nystagmus, and prevention and treatment of amblyopia. So the next 20 minutes I will talk about how to do normative values of visual function in children and of optic abnormalities in NF1 and NF2 related schwannomatosis. Measurement of visual acuity is important in managing any ocular condition and has always remained a challenge in infants and young children. Rating acuity tests are based on the preferential looking method and can be used to measure visual acuity in pre-verbal children. It's a device for measuring visual acuity by displaying a light background with a set of evenly spaced dark bars whose width and distance apart can be reduced until the minimum separator is reached. The tester's task is to judge the child's visual acuity based on his behavioral reaction, that are eye movements, head movement, or pointing gestures. The most important guide is the initial eye movement. The most common tests are the tele-acuity cards. You can see them on the picture right on the top. Other tools are the layer grading pedals and the Cardiff acuity test. Visual acuity obtained with tele-acuity cards is expressed in cycle per degree, and visual acuity of 2020 corresponds to 24.98 cycles per degree. Optotype acuity testing is a psychophysical examination the child has to detect, to discriminate, and to recognize an optotype. Visual acuity can be tested with single optotypes or with line acuity tests. You can see pictures of them on the right side. The most common visual acuity tests for children are the layer symbols, HOTV, and the early treatment diabetic retinopathy study charts. In some cases, both single letter and line acuity are performed because of the so-called crowding phenomenon that is a typical symptom of amblyopia. Crowding is the impairment of the ability to recognize objects in clutter. Visual acuity testing with single optotypes shows better results than with line optotypes. Crowding ratio means the ratio uncrowded acuity to crowded acuity. Crowding has a development effect in typically developing children 3 to 4 years old. The crowding ratio is 1.8. It is decreasing with age. And at age 5 to 7 years, the crowding ratio is 1.6 to 1.2. A crowding ratio more than 2 is a typical sign of amblyopia and cerebral visual impairment. Different visual acuity tests can be used in a pediatric population, so I would like to give a very short overview on this topic. Both Linton and colleagues and Bowman and Preston described a good correlation between the visual acuity using layer gradient pedals and tele-acuity cards. Bowman and Preston found that infants up to 12 months performed the tele-acuity cards better. The Cardiff acuity test proved to be easier to use for the 12 to 36-month-olds. There are reports from Sharma 2003 and Howard and Firth 2006 that the Cardiff acuity test tends to underdiagnose reduced visual acuity caused by refractive errors. Hagedorn and colleagues from where they initially used tele-acuity cards for the early treatment diabetic retinopathy study charts and showed a good agreement of the visual acuity tested with both EDDRS and tele-acuity cards in 6-year-old children. Which method at which age and how much visual acuity lower limit? In the first 2 years of life, we use preferential looking methods. At age 2.5 to 3 years, we start using layer grading single optotypes. From the age of 3.4 to 5 years, children are mostly able to perform a line acuity test. Visual acuity develops with age. The lower limit at age 1 is around 1.0 and increases until age 8 to 9 years when adult values of 2020 are reached. Refraction, ametropia, and anisometropia in NF1 and NF2 related schwannomatosis. Let's start with the group NF1 without any ocular or orbital pathology except lesionogenous. The studies of Akinci, Ardagil, and Dotum showed a higher prevalence of mild and moderate myopia and a higher need for optical correction. Additionally, Ardagil and colleagues found a higher frequency of anisometropia and amblyopia among young NF1 patients. In contrast, Fage and colleagues did not confirm that. They found that refractive errors such as myopia, hyperopia, and astigmatism were similar between the NF1 and control group. So further research is requested. And next, we talk about the comparison of refractive anomalies in NF1 with and without unilateral optic nerve glioma. Both Fage and Dotum showed the same result, that an unilateral optic nerve glioma is not related with an increased prevalence of anisometropia. Avery and colleagues found in a cohort of orbitofacial neurofibromas a spherical refractive error on average of minus 2.63 diopters more in the affected eye than in the unaffected eye, and 65.2% needed optical correction, mainly myopic. In the NF2 patient group, both Kinsey and Foyt described similar higher frequency of mild and moderate myopia. The assessment of visual field and performing perimetry in infants and young children is always a challenge. The common conventional standard perimetry methods include the manual kinetic Goldmann perimetry and other static automatic computer parameters. They require steady fixation and cooperation of the child. We will talk about them later. In very young children, different confrontative behavioral methods like the Dundas method, based on the detection of moving fingers of the examiner, or small toys or sticker balls, are commonly used. They are not very precise measurements, and only peripheral visual field effects can be detected. In my opinion, the so-called BFI test, behavioral visual field test, is a good option. You can see a picture on the right. It consists of a graded arc, a fixation target, and positioning stick, and requires trained observer and examiner. I believe it has the advantage of the graded arc, so that it allows a quantitative assessment. Nonetheless, only the peripheral visual field can be evaluated. We ordered this tool for our neuro-ophthalmology clinic, but we haven't received it yet, so unfortunately I cannot share personal experiences with you. Eye-based examination may become a promising tool in the future for children unable to perform standard perimetry. For example, saccadic vector optokinetic perimetry uses eye tracking technology to measure-based responses to stimuli presented on a computer screen. Standard conventional perimetry in children and normative values. Visual field testing using computer perimeters and static programs is often difficult to perform in children because of a high number of fixation errors and false positive and false negative errors. The most effective conventional perimetry method in young children is still the manual kinetic Goldmann perimetry. Unfortunately, Goldmann perimeter is no longer available, but there are computer perimeters, for example, Octopus and Humphrey, that offer kinetic programs too. Visual field size and sensitivity increase with age in patterns that are specific to the parametric approach used. Visual field area increases with age. Visual field development occurs predominantly in the inferior temporal field. Humphrey mean deviation shows an increase of 0.3 decibels up to 12 years of age when adult MD values were reached. These developmental changes should be taken into consideration for interpreting parametric test results in children. The last minutes I will talk about optic abnormalities in NF1 and NF2 related schwannomatosis. Ptosis, exophthalmometry, and eye protrusion in pediatric age. Normal value of eye protrusion could vary according to the ethnic origin, age, sex, height, and weight of subjects. Initially, an orbital disorder is suspected when exophthalmometric values are outside of the normal range or when there's more than 2 millimeters differences between the eyes. Eye protrusion grows like the child, you can see it in the table below. Protrusion of the eyeball in NF1 can occur as one of the early signs of an optic nerve glioma, but it can also imply sphenoid wing dysplasia, orbital neurofibroma, or a large globe alone or in combination. The prevalence of ptosis in NF1 optic pathway glioma ranges from 5.42 to 13 and up to 20 to 30%. In NF1, orbitofacial neurofibromatosis, Chaudhry and colleagues reported a ptosis in 56.6%. In NF2, Bosch and colleagues observed in their retrospective study of 23 patients in 39% ptosis. Ptosis and lid abnormalities in NF1 and NF2 related schwannomatosis. Avery and colleagues reported in their multidisciplinary recommendations for OPN care that ptosis as main symptom is seen in nearly 100%, and that OPPNs tend to grow rapid in the first years of life. They described 3 anatomic locations: first, isolated upper lid; second, eyelid and periorbital region, a progression into the orbit is possible; and third, orbit with or without eyelid involvement may invade lateral orbit and can invade the cavernosus sinus. You can see a picture on the right side. Associated sphenoid dysplasia can occur, and this can cause compression of the optic nerve and the extraocular eye muscles. Visual loss caused by refractive amblyopia occurs up to 43%, deprivation amblyopia from ptosis in 1/3 to 1/2 of the children, and strabismic amblyopia in 10 to 20%. I recommended an eye exam at a minimum every 6 months up to age 8, including visual acuity testing, cyclopletic refraction measurement, evaluation of eye motility and strabismus, measurement of intraocular pressure, pupil examination, and if possible, stereopsis and color vision. In NF2-related schwannomatosis, Bosch and colleagues found in their retrospective study of 23 NF2 patients in 77% impaired lid dysfunction due to Horner syndrome, burden of palsy, or postoperative facial nerve palsy. Amentano and colleagues described in the cohort of 14 patients in 14.3% ptosis, in 28.6% lack of thalamus, and 1 patient presented Duane syndrome 1. Nystagmus in NF1 and NF2-related schwannomatosis. Briefly summarized, there are several studies that demonstrate that nystagmus is not a presenting symptom in NF1-related optic pathway gliomas and is more often seen in non-NF1-related patient groups. Regarding nystagmus in NF2, Bosch and colleagues found in a cohort of 73 patients in 50% nystagmus, mostly peripheral vestibular nystagmus. Others were downbeat nystagmus, gaze-evoked nystagmus, latent nystagmus, and 1 patient presented sensory nystagmus. Amentano colleagues described physiological nystagmus in extreme gaze positions in 57%, and Painter and colleagues 2019 observed frequently gaze-evoked nystagmus in their cohort. Prevalence of strabismus in NF1 children with and without optic pathway glioma. Previous studies described strabismus as a symptom in NF1-related and in non-NF1-related optic pathway gliomas in children ranging from 2.6 to 12 to 50% and up to 66%. Mostly they described an exotropia in the affected eye with the reduced vision. There are 3 studies based on similar patient cohorts, and we see the prevalence of strabismus in the NF1 optic pathway glioma group is 27 to 28.9%. Toten and colleagues compared the frequency of strabismus in NF1 children with and without optic pathway glioma and found a strong association between strabismus and optic pathway glioma. NF1 children with optic pathway glioma have a 4.13 times higher relative risk of developing strabismus than NF1 children without optic pathway glioma. Characteristics and typical features of strabismus in NF1 with and without optic pathway glioma. Summarized, exotropia is the most common strabismic type. It is often associated with the hypertropia. Ptosis is frequently combined with hypertropia, and mostly it's a sensory strabismus. Hannes Josefon and colleagues pointed out an important finding that described that the development of strabismus led to the diagnosis of both NF1 and optic pathway glioma in 4 patients, and the diagnosis of optic pathway glioma in another 2 with known NF1. So this emphasizes the importance to examine visual acuity, the pupillary reaction, the optic nerve, and the possibility of lesion nodules during the initial evaluation of strabismus. Strabismus and eye motility abnormalities in NF1 orbital periorbital plexiform neurofibromas. Ocular misalignment is a frequent OPPN-related symptom. Severe reports describe strabismus from around 50% up to 75%. Strabismus in OPPN may be mechanical, caused by tumor infiltration, compression of the eye muscles and orbital tissues, globe displacement, increased axial length, or secondary to orbital and sphenoid wing dysplasia, or sensory due to vision loss. Weistrick and colleagues evaluated in a retrospective study the causes of ocular motility disturbances in orbitofacial neurofibromatosis in 49 patients, including a detailed examination of ductions and incompetency of strabismus. Summarized, they found anatomic abnormalities do not always cause limited ocular motility. Strabismus is generally not seen in full eye motility and good vision. Worse visual acuity is connected to a higher incidence of strabismus, both comitant and incomitant. Hypoglobus was always associated with sphenoid wing dysplasia on neuroimaging, and only one patient had a neurogenic cranial nerve palsy after the building of orbital tumor. Strabismus and extraocular cranial nerve palsies in NF2-related schwannomatosis. Different generic terms are used in the literature, for example, oculomotor deficits or eye motility disorders. Other authors differentiated between strabismus and eye motility disorders and used a more precise definition like concomitant, inconcomitant, or non-paralytic strabismus. Cranial nerve palsies 3, 4, and 6 can be caused by schwannoma of the nerve or develop depending on the location of a central nervous system tumor. Overall, there is a higher amount of both concomitant and inconcomitant strabismus. The studies of Voigt 2008 and Armentano 2023 found a similar percentage of strabismus of 50 and 52% respectively. Concerning the forms of concomitant strabismus, Armentano and colleagues found microtropia, intermittent exotropia, esotropia, and one patient presented Guan-1 syndrome. Voigt and colleagues described combined horizontal and vertical deviation in 3 patients. The other 16% had half and half convergent and divergent strabismus. The generic term motility disorder is described in up to 70%. The percentage of extraocular cranial nerve palsies in the literature ranges from 4.8 to 24.1%. Cranial nerves 3 and 4 are often affected ocular cranial nerves, and combined and bilateral occurrence is observed too. Stereopsis and stereoacuity. Stereopsis is the ability to perceive depth due to relative binocular image disparity. Stereoacuity is expressed in arc of seconds. As a screening tool, the lung-1 test can be successfully used in children as young as 6 months up. Decreased stereoacuity can be caused by uni or bilateral visual acuity reduction, visual deprivation, uncorrected reflective errors, strabismus, and nystagmus. Stereoacuity develops with age. Age norms are 150 seconds of arc for ages 3 to 4 years, 70 seconds of arc for ages 4 to 5 years. At age 5 to 7 years, stereoacuity of 30 to 60 arc of seconds, like adult values are real. In NF1, Parnes Josifon reported in their group of 76 NF1 related optic pathway glioma patients a lack of stereoacuity in most patients. Only 22.7% demonstrated stereo vision on the Titmus stereo test, ranging from 40 to 3,000 arc of seconds. In NF2, Voigt and colleagues found in the cohort of 73 NF2 patients in 58% normal and in 8% subnormal stereoacuity. In 34%, no stereoacuity was present, and it was tested with the lung-1 stereo test. Take-home message of topics in NF1 and NF2 related schwannomatosis. A quantitative measurement of visual acuity should be performed as soon as possible. The teleacuity cards can be used from the age of 2 months up. NF1 and optic pathway glioma and strabismus. Exotropia is the most common strabismic type and mostly it's a sensory strabismus. NF1 children with optic pathway glioma have a 4.13 times higher relative risk of developing strabismus than NF1 children without optic pathway glioma. NF1 and orbitofacial neurofibromatosis. Amblyopia is mostly multifactorial. Refractive amblyopia arises in up to 43%. Deprivation amblyopia from ptosis occurs in 1/3 to 1/2 of the children, and strabismic amblyopia in 10 to 20%. From my optic viewpoint, I would like to emphasize the importance of amblyopia treatment, like eye patching, to improve the treatable portion of amblyopia. Eye motility and strabismus. Strabismus is seen in 50 to 75%. It is frequently associated with worse visual acuity. Concomitant strabismus combined with limited adductions is seen in around 50%. NF2-related schwannomatosis. There's a higher number of refractive errors, strabismus, and increased risk of vestibular nystagmus. As generic term, oculomotor deficits and motility disorders are described in up to 70%. The frequency of strabismus is 20 to 52%. The percentage of extraocular cranial nerve pulses 3, 4, and 6 ranges in the literature from 4.8 to 24.1%. Cranial nerves 3 and 4 are often affected cranial nerves. Both combined and bilateral pulses may occur. A careful orthoptic assessment is necessary for early detection of strabismus, eye motility disorders, and nystagmus and vestibular dysfunction. Thank you for your attention.
Good evening, everybody. I'm Bertolt Pemp from Vienna. I'm the head of the neuro-ophthalmology clinic at the University Hospital, and I thank the organizers for the opportunity to talk about ophthalmologic findings in neurofibromatosis type 1 and type 2 related schwannomatosis. The current diagnostic criteria for neurofibromatosis type 1 include several features related to ophthalmology, and hence ophthalmologic examination is often essential in diagnosis and also observation of this systemic disease. One of the most frequent changes found in eyes of NF1 patients are the long lesion nodules, which are brownish colored dome-shaped hematomas of the iris pigmented epithelium, easily recognizable in bright eyes and less easily seen in brown eyes. Histologically, they consist of pigment cells, fibroblasts, and mast cells. They are not exclusively found in NF1, but also sometimes in NF2 and the Legius syndrome patients. The lesion nodules tend to be more frequent in the lower iris region. This may be due to more frequent UV light exposition of the lower part of the eye, due to the coverage from the upper lid in the upper region of the iris. Lesion nodules increase numerically in NF1 patients with age, reaching a frequency of nearly 100% in young adults. Differential diagnosis for lesion nodules are the rare findings of iris mammillations, which are more regularly configured in the iris, brush field spots, which are not pigmented, nodules in the peripheral region of the iris, and flat pigmented areas corresponding to navy. Another very frequent finding in NF1 patient eyes are the so-called choroidal nodules. They are not visible in ophthalmoscopy, but only when infrared light is used for retinal imaging, where they appear as bright spots over the background. They were first described in the year 2000 and are now one of the diagnostic criteria for NF1. In other imaging, using optical coherence tomography, they correspond to choroidal aggregates, and histologically they consist of hyperplastic Schwann cells and melanocytes, so these are kind of hematomas of the choroidal tissue. The appearance of choroidal nodules also relate with the presence of optic pathway glioma. They are rarely seen outside NF1, so they are disease-specific for this systemic. Nodules can increase in size and number over time, as seen in this patient example observed for a period of 5 years. And the frequency of this finding increases similarly to lesion nodules during aging, so that nearly all adult NF1 patients have these choroidal neurofibromas. Sometimes there are also fundoscopic correlates of this change, presenting as hyperpigmented spots with increased melanocytic content, or has yellowish subretinal nodules when more Schwann cells are contained in the lesions. In addition to these small tumors, NF1 patient eyes also more frequently than normal show retinal vessel anomalies. NF1 generally is associated with frequent systemic vessel anomalies, and in the eye we often see abnormal triple branching of retinal vessels, or also venous anomalies, including frequently found venous loops, or more dense corkscrew veins, or the very dense Moya-Moya type anomaly. The latter two have a very high specificity for NF1 diagnosis. These venous changes also progress over time, as seen in this example. Larger retinal tumors are a more rare finding in NF1, but also possible. These include capillary hemangiomas and peripheral retinal hematomas, combined hematomas of the retina and the retinal pigment epithelium, or also vasoproliferative lesions of the peripheral retina. NF1 patients can also present with changes on the eyelid. This includes simple café au lait spots, of course, but more severely ocular neurofibromas. These are tumors of the peripheral nerve sheaths, and the more severe form is the plexiform neurofibroma. If it is growing orbitofacial, it can grow extraorbitally or intraorbitally, leading to severe symptoms. Sometimes the conjunctiva is also involved, and they are difficult to treat. Surgical removal is often impossible, since they tend to grow diffusely in the tissue. That's also why relapses are very often after surgery, and there is also a possibility for malignant transformation. These tumors can now be treated with new therapeutic agents, including selumetinib or trametinib. Cerebral tumors are quite frequent in NF1, and of all the cerebral tumors, the optic pathway glioma is the most frequent one. 10 to 30% of NF1 patients have the diagnosis of an optic pathway glioma. This is more frequently found in children, but it can also develop or only be detected later on in adolescence. A recent animal model of NF1 showed that tumor growth of the optic glioma depends on neural activity in early life and is mediated by neuroligin 3. Histologically, optic pathway gliomas are mostly pilocytic astrocytomas. They feature an intrinsic growth inside the optic nerve, hence the nerve is not compressed from the outside, and the tumor cannot be operated. The nerve fibers show an irregular axonal course and myelin degeneration, leading to impaired axon-glia interaction and neuronal dysfunction, and eventually to apoptotic loss of many nerve fibers. This also results in visual acuity reduction in many cases. The amount of visual loss is associated with maximum optic nerve thickness, but not with the tumor volume contrast enhancement in the MR imaging. The tumor location can be classified according to the Dodge classification system, roughly into pre-chiasmatic, chiasmatic, and post-chiasmatic lesions, leading to different types of visual field defects. Tumors tend to progress in many cases, especially in patients that are symptomatic with visual disturbance. There is also a possibility of spontaneous regression, especially in asymptomatic patients. Available treatments include agents like carboplatin, vincristine, and more recently developed biologics. Unfortunately, the treatment response rate is quite low. About half of the cases with optic pathway gliomas become symptomatic. This affects mostly children of young age. They experience a loss of visual acuity and the emergence of visual field defects. But because children do not express visual disturbance by themselves in many cases, they deteriorate unknown and present only later when the visual function is severely affected with strabismus or nystagmus and eyeball protrusion. Clinically, the optic nerves can present as atrophic, as a sign of descending degeneration of the optic nerve fibers, or also with papilledema as a sign of axonal dysfunction. Atrophy and also swelling of the optic nerve head can be measured in good detail with optical coherence tomography. This is possible in patients from the age of 2 to 3 already. Since atrophy of the optic nerve is an unspecific sign for any optic nerve lesion, OCT is not an ideal screening tool for NF1 as such. There is also a weak correlation with visual acuity and high inter-individual variance. But in patients with known NF1, OCT has a high specificity for optic nerve glioma. And it is a sensitive morphologic biomarker for progression of optic atrophy with a short latency when ganglion cell layer thickness is measured, and also for the progression or regression of papillary swelling with a short latency. Results from OCT should always be compared with functional testing to evaluate the results. Most chiasmal gliomas can present as in this patient with a specific pattern of optic nerve and retinal layer degeneration. Different methods are used to measure different aspects of visual function, and there are subjective and objective tests available. The most important test categories in optic pathway tumors include visual acuity, color discrimination, perimetry, and the objective comparison of the pupil reflexes in both eyes. All these methods can be used in children with different modalities according to their age. Visually evoked potentials, another objective test, has a good sensitivity for tumor detection, but it has only a weak correlation with visual acuity and a high inter-individual variability. As you heard before, visual acuity testing in children is performed using different methods according to the children's age. However, standardized charts should be used whenever possible to enable exact follow-up. Physiologic visual acuity develops rapidly during the first year of life. However, since visual acuity testing is a psychophysical method, it needs cooperation of the patient, and the results are limited by the stage of neural development. Nevertheless, visual acuity is the most reliable functional parameter in early childhood. Norm values are available from a very early age on using the age-appropriate testing method, and lower limits are also available, and actual results in patients with optic pathway glioma can be used to detect deviations from these normal limits, and can also have an impact on treatment decision during progression of the disease. Results of visual acuity testing at presentation or significant worsening during follow-up can have an influence on treatment decision alongside progression signs in imaging. In long-term follow-up, it seems that an abnormal optic nerve head and abnormal visual acuity are the main long-term predictors of visual acuity in optic pathway glioma. Therefore, regular ophthalmologic screening examinations should be performed in all NF1 patients. Children under the age of 8 should be examined every 6 months, older children every 12 months. If an optic pathway glioma is detected, 4 exams should be performed during the first year of observation, and if there is a stable situation, intervals can be extended to 6 months. Methods to include are visual acuity testing with a method appropriate for the age of the children, perimetry testing, and at least fundoscopic examination of the optic nerve to detect atrophy or swelling. OCT should be used preferably because it has the advantage of higher sensitivity to detect morphologic changes. If there is a significant loss of visual acuity or a new visual field defect, this has an influence on treatment decision by the pediatric oncologists. Deviations in different tests can have an influence on shortening of the exam interval. Neurofibromatosis type 2 also often has characteristic ophthalmologic findings. 40% of cases feature an eye disorder as a first sign of the disease. Many suffer from early onset visual loss, which can lead to strabismus. A very frequent change is the presenile cataract in 70% of cases. If this is present in an infant, it has to be removed shortly to enable normal development of visual function. Another frequent finding is an epiretinal membrane, papillary glioma, optic pathway tumors, retinal hematomas, and more rarely, retinal hemangiomas or niche nodules of the iris. If there is an intracranial tumor present, secondary changes to the optic nerve can appear, including papilledema or optic atrophy. There can also be cranial nerve palsy, leading to strabismus or keratopathy. The frequent epiretinal membrane in neurofibromatosis type 2 is present in early childhood already. It is more frequent in early onset NF2 and independent from retinal tumors. Histologically, these are proliferating Müller cells and astrocytes. The epiretinal membrane is typically flame-shaped. It can have vitreoretinal traction and can also lead to retinal folds. Usually this is a stable course. Optic nerve sheath meningioma is a more severe finding. It is rare in children without NF2, but 30% of cases of optic nerve sheath meningioma in childhood are associated with NF2. It can stay asymptomatic, or it can induce optic nerve compression with visual loss, visual field defects, and also exophthalmos. Fundoscopically, it can lead to papilledema and also optic atrophy. Both features can easily be recognized using optical tomography. Retinal tumors in NF2 are more rare, but can be possible. These include combined hematomas of the retina and the retinal pigmented epithelium, retinal hematomas. Both are possibly already congenital. They usually are stable in their course. Sometimes these thickenings of the inner retina are only recognizable with optical coherence tomography, especially if they are very, very small. More subtle retinal changes in NF2 include macular chorioretinal hypertrophy with atrophy of the retinal pigment epithelium. Thoracoscopically, this presents with only minimal changes, but there is marked hyperfluorescence in fluorescein angiography due to the loss of retinal pigment epithelium. When such a lesion reaches the central macular area in the fovea, visual acuity can also be impaired. To conclude, visual loss due to specific manifestations in NF1 and NF2 schwannomatosis mostly develops during early childhood. Small children, however, do not report a reduction in vision by themselves. Visual function is all the more important in children with neurological impairments like in NF1 and in possible hearing loss in NF2. Therefore, regular eye examinations are essential for patients at risk in order to maintain visual function and provide timely treatment. The diagnostic effort in infants is often very high, and recommended standards are only easier to meet from school age onwards. But the methods used must be tailored to the individual case and age, and always evaluated in context with each other and with other neuro and radiological findings. I thank my team for their efforts in these patients, and I thank you for your attention and interest. I'll be happy to discuss any questions you have.
Thank you very much, Sabine and Bertold. We are now open for a Q&A session. Thank you for this very great and very thorough, also retrospective analysis of all the data. We have a question from Amedeo Azizi. The high frequency of strabism is astonishing and is more than expected. Is covering an eye the treatment of choice, as in other conditions of strabism? And how often do children with NF1 need strabism surgery? So the first question is covering an eye a good option, like in other strabism cases? Who would like to take that question? You both are muted, Sabine and Bertold.
It's a good question, Amedeo. Thank you. It depends. If the strabism is caused by optic nerve glioma, amblyopic treatment may not work like expected. But however, if the strabism is caused by refractive error, which is also present in many children, standard treatment should be performed with occlusion treatment. It depends, as I said, on the cause of the strabism and the cause of the visual dysfunction in the eye. So primary treatment may depend on the underlying pathology, and strabism surgery should be applied from case to case if it's needed, only after the treatment that is needed specifically for the strabismic eye.
Thank you. We have an attendee, Maria Liotti-Lipolis. You have raised your hand. I need to ask you to use the chat or the Q&A box to ask your questions. I'm afraid we can't directly interact with the lecturers today. I would have a question myself regarding the NF2 and the defects that are seen due to a cranial nerve palsy. I wondered if these cranial nerve palsies were due to a tumor pressing, or was it just due to the cranial nerves being somehow affected by, but not directly related to a tumor?
Most cases may be due to the tumor growth in the region of the oculomotor nerve. So a compressive lesion in the course of the nerve may be the primary pathology of paretic strabism in these patients. Did I understand your question correctly?
Yes, you did. Thank you, Bertolt. There's actually a question directed to you, Bertolt, from Amadeo Azizi again. He wondered if you could comment on the retinal changes seen upon MEK treatment, MEK inhibitor treatment, and if you just watch and wait, you intervene with steroids, you halt the treatment, and what are your criteria for deciding which route to take?
This is an increasing problem we have because it demands a lot of examinations in patients treated with those modern medical agents. Nevertheless, we have the opportunity to use OCT regularly in these patients, and some react with delineation of the neuroretina, sort of an detachment in the central area mostly. Fortunately, this is not present very often, but in some patients, it can be a recurring problem, which in many cases responds very nicely to steroid treatment. Short-term oral steroid treatment usually results in resolution of the fluid, of the subretinal fluid in these cases. Sometimes, if it's minimal, the retina or the pigment epithelium is also capable of pumping this liquid out by itself. So if it's only minimum, one could also wait and see. So if it's growing over several months, it can be treated with steroids. And if it's too much, if there's much fluid leading to a real detachment, it can also have influence or impact on the MEK inhibitor treatment that should be halted for a period at least. So OCT gives us a nice opportunity to control side effects, ocular side effects of this treatment, but it needs regular monitoring using these machines.
I would add, are there any positive side effects of MEK treatment on the eye at all?
Positive side effects?
Yeah,
positive. I don't understand.
In the sense that, well, typically the patients are treated for their plexiform, but then they're being followed, and I wondered if there was some changes, some positive changes that you saw as well in MEK treated patients.
Well, if the tumor regresses, it's a positive change, but that's a treatment aim and no side effect.
Yeah.
So other positive signs I'm not really aware of. Do you know something, Sabine? No, she says
and
no.
Going back to the visual acuity testing of very, very young children, I understand that, especially in OPG cases, they can occur in infants. And I was wondering if you think that there is a need to develop special tests for infants at all, or if the current testing machine is good enough for infants.
In my opinion, yes. Or perhaps Sabine has a lot of.
Sabine, you are muted. Sorry.
No, in my opinion, I agree to Bertolt. I think we have good possibilities.
These tests are very good, evaluated and standardized, and I think invention of new ones would only limit our examination procedures, because this has to be evaluated for in large amount of patients until it's also established. And the current standards are very good established standards.
And how variable is reaching the development of visual acuity in the first couple of years? How standard is it? I mean, is there a big variation between children, or is it pretty standard that all children actually follow a more or less the same path, but to what extent is that path the same?
In healthy children, it's quite good known. So there is a quite standard development of visual acuity. Of course, neurofibromatosis type 1 children especially, they do also sometimes feature deficits in their neurodevelopment. So cognitive problems can limit also the testing itself. But nevertheless, we have lower norms, lower limits in children that also should be valid in those children, at least to get a feeling if there may be a problem with the optic system. So we can rely on these standard measurement values in a very confident way.
And you are both you both work in a multidisciplinary team, you know, of NF1 and NF2 multidisciplinary teams. So you are fully involved with all the patients. But I was wondering if, you know, ophthalmology in general was not outside of your practice, of course, but if you found that, you know, in NF patients, there tends to be, you know, a minimization of this specialty because of the tumor burden, and because because the patients may be more concerned about the tumors that are much more symptomatic. I wonder, you know, how widespread is it that ophthalmologists such as you are involved in NF clinics, and if you would actually, you know, recommend your colleagues to actually see in their own countries and in their own regions where they work, whether this is actually the case, that NF children are being followed by an ophthalmologist as well.
We are in the lucky situation that we have this neurofibromatosis center in our hospital, and we have a close cooperation with the neuropediatric oncologists. And if it's not possible in a center to have an ophthalmologist, a close cooperation should be sought, in my opinion, because most patients won't need very short-term follow-up, but some really do need short-term follow-ups for the visual function, especially during the decision whether treatment is necessary or not. So a close cooperation seems necessary for every neurofibromatosis center.
But could you comment on how common it is to have such involvement, you know, in Europe? Do you feel like you're one of the few, or one of the too few, or?
I don't have a good feeling for the other countries, but I see there is a lot of interest and a lot of networking done in this disease. So I hope that the interest is growing, and also the centers that are cooperating, or the cooperation between centers is also evolving.
Well, I can't see any other questions. Sorry, there's yes, there is a comment from Amedeo, who says that in young children, stable vision may actually mean visual deterioration compared to age-matched children.
If you see only the number, you can have this wrong opinion. But if you respect the age-related development and know the normal values for the age, you cannot be wrong then if you compare it to the normals. So an important, very important point, of course, but ophthalmologists should know that, and that's why the children doctors need the ophthalmologists.
Well, I thank you both, Sabine and Bertolt, for your very thorough lecture and for being with us today. And I thank also the audience for being participative, and to Amedeo for all these interesting questions. This masterclass is now over. it will be on the YouTube channel for you to watch it again as soon as practically feasible. I hope by the end of the week it will already be on the YouTube channel. So if you want to go back to the presentation and look again at all the data that especially Sabine has been showing, which I think will need a bit of studying, more studying. And I thank everyone. And the next masterclass has already been scheduled for January 24th. And in the coming weeks, we will schedule some more up until the summer. I look forward to seeing everybody and thank especially Bertolt and Sabine again. And I hope to see you soon.
Thanks for having us.
Bye-bye.
And happy holidays to everybody.
Happy holidays.